Good day everyone. Today we will be discussing about decision making in planning management of congenital heart disease. I am Dr. Abhay Pota. I am assistant professor in pediatric cardiology at UNMICRC Institute of Cardiology and Research Center. So essentially, I know the diagnosis, whether it is VSD or PDA or TGA or TAPVC or complex single ventricle. So what next? I have done the CT. I know full diagnosis, but how to plan? How to plan the further management? So whether I intervene, whether I not intervene, and whether to wait or not, and if wait, to wait for how long? If it is intervention is urgent, then how urgent? What is the way in which I can intervene? Cath, medical management, surgery, what? Uh, or just to follow up, or no follow up at all. So these all things we will be discussing today. So management of complex congenital heart diseases, or in fact any type of congenital heart diseases, involves multiple factors. Congenital heart diseases have complex anatomy, and their physiological effects are also multiple. Multiple factors influence their planning of congenital heart disease. They commonly have syndromic associations, and multidisciplinary care is required. Hemodynamic understanding is the key. Main part is physiology. Hemodynamics or physiology is the understanding. Hemodynamic understanding is the key in management of congenital heart disease. So basically, as we will see, a lot of factors need to be accounted for before charting out a treatment plan. Besides, I have omitted social and administrative factors like cost issues, availability of expertise at different centers, social support for post-operative care, etc. We will be mainly focusing on hemodynamic and clinical factors. So our learning objectives for today's discussion will be, this talk is going to be an overview of what all congenital heart diseases are out there and their underlying hemodynamic concepts. Why we do what we do in management of congenital heart diseases, which are the treatment modalities, cath, surgery or medical management. When do we intervene, and especially when do we not intervene? This talk is not going to be about any detailed disease specific planning. It is just an overview of decision making process. Aim is to provide a mental framework for making decisions after thoroughly understanding the underlying concepts. So besides the traditional acyanotic, cyanotic and obstructive congenital heart disease classification, the main physiological classification of congenital heart disease is pre and post tricuspid shunts, TOF physiology, that is VSDPS physiology, admixture physiology, including single ventricles, TGA physiology, Eisenmenger physiology, and duct-dependent lesions. Pre and post tricuspid shunts like atrial septal defect, ventricular septal defect, PDA, AP window, AV canal defect. Then in TOF physiology, TOF, DORV VSDPS, TGA VSDPS, CCTGA VSDPS, single ventricle VSDPS, AV canal VSDPS, these are the common examples. In admixture physiology, common atrium, truncus arteriosus, TAPVC, DORV. Then in TGA physiology, TGA itself, TGA with intact septum or TGA with VSD. In Eisenmenger physiology, any shunt lesion which has developed pulmonary vascular obstructive disease. And lastly, duct-dependent lesions, duct-dependent systemic circulations like HLHS, aortic atresia, severe aortic stenosis, severe coarctation, or like duct-dependent pulmonary circulation like TOF pulmonary atresia, PIVS, or any form of there is pulmonary atresia associated with duct-dependent pulmonary circulation. Knowing this helps in initial stabilization and management and guides in determining timing and modality of intervention, and also helps with prognostication. So what are the physiological effects of congenital heart diseases? So first of all, acyanotic congenital heart disease, pre and post tricuspid shunts. Common lesions which are ASD, which causes volume overload of RA and RV, VSD, which causes volume overload of LA and LV, and also causes systolic pressure is transmitted to PA. Then in PDA, there is volume overload of LA and LV, along with systolic as well as diastolic pressures of are transmitted to PA. Next, cyanotic congenital heart disease. In cyanotic congenital heart disease with decreased pulmonary blood flow, including Eisenmenger syndrome, main physiological effects are hyperviscosity and coagulation abnormality, and cyanosis, which eventually lead to hemoptysis, thromboembolism, infective endocarditis, gout, chronic kidney disease, and various other complications. Cyanotic congenital heart disease with increased pulmonary blood flow, shear stress to pulmonary capillaries, and hypoxia-induced pulmonary vasoconstriction, as well as volume overload of the ventricle. These are the physiological effects which eventually lead to pulmonary vascular obstructive disease or Eisenmengerization and heart failure. Transposition physiology. In transposition physiology, there is parallel circulation. Normal is in series circulation, while in transposition physiology, there is parallel circulation. This parallel circulation ultimately leads to shock and cyanosis unless there is adequate mixing between the systemic and pulmonary circulations. Duct-dependent circulation. As we have already discussed the examples, decreased QP or QS with ductal closure, which occurs with time in the first month of life, can lead to shock and cyanosis in those conditions. Next is obstructive congenital heart disease. Systemic outflow tract obstruction like AS and coarctation can lead to left ventricular hypertrophy and eventually LV dysfunction, while pulmonary outflow tract obstruction like any form of PS can lead to RV hypertrophy, RV dysfunction, and cyanosis if there is PFO with right to left shunt. So next is why we do what we do. What are the overall aims of treatment? So overall general aims are first, separate systemic and pulmonary circulations. Say for example, normal is in series circulation. In TGA there is parallel circulation. We do not want parallel circulation. We want to have in series circulation. And next, we do not want any form of shunting or mixing. So we want to close all types of shunt which are there between systemic and pulmonary circulations. Next is we want to maintain QP/QS ratio of 1:1, not more than 1:1, not less than 1:1. Secondly, oxygenation at low PA pressures. So whole point of separating circulation is to promote adequate gas exchange. So we want to promote gas exchange, and gas exchange is promoted at low PA pressures. It occurs better at low PA pressures. So important physiological concepts here are pulmonary hypertension, pulmonary vascular obstructive disease. These lead to inadequate gas exchange. So we want to promote oxygenation at low PA pressures. So low PA pressures are required. Thirdly, optimum systemic oxygen delivery. We want to deliver optimum systemic oxygen. Now important physiological relevant concepts here are right to left shunt or pulmonary or systemic venous obstruction. Say in case of mitral atresia, there is restrictive ASD is there. So despite the pulmonary venous blood coming normally to LA, it does not have any egress. So we have to do atrial septectomy or atrial septum balloon dilatation to give it an egress. Otherwise systemic oxygen delivery will be impaired. Or same way, in case of tricuspid atresia or pulmonary atresia intact septum, if there is restrictive ASD is there, we have to enlarge it. Next is right to left shunt. In cases of TOF, systemic, because of right to left shunt, systemic output is maintained, and but if there is, in case of TOF, there is restrictive VSD, patient can go into shock. Then we have to protect ventricles against volume and pressure overload. Important physiological concepts here are preload, afterload, and in certain cases of single ventricle, forward flow or antegrade flow. We will discuss all these physiological things later in detail. Next is to maintain patent circulatory flow in duct-dependent systemic and dependent pulmonary circulations. So essentially, what all these physiological aims want to convey are shunt closure. We do not want any shunt. We do not want mixing. No significant AVVR should be there. Unobstructed systemic and pulmonary venous return should be there, and unobstructed systemic and pulmonary arterial blood flow should be there. This is largely true for biventricular circulations. We will see what is different about single ventricle cases, because in single ventricle cases at different stages we want mixing and as well as no mixing. At different stages it is different. So key hemodynamic concepts here are, so hemodynamic impact of various factors. So what are the hemodynamic factors? Duct dependency and timing of duct closure, which is important in cases of duct dependent circulations as well as in cases of shunt lesions. In cases of PVR, pulmonary vascular resistance, it is important in cases of shunt lesions, because pulmonary vascular resistance, once it falls, shunt lesions start to manifest. Shunting and QPQS ratio, which is important pre-operatively, as well as I have mentioned a few post-operative examples also, like in cases of BT shunt, Glenn and pre-Fontan. Say for example, in cases of BT shunt, we want QPQS ratio of 0.3 to 0.4. In cases of Glenn, we want QPQS ratio of 0.4 to 0.6, and after Fontan, we want QPQS ratio of 1:1. Volume overload, which is important cases of shunt lesions and Eisenmengerization. In shunt lesions, there is volume overload. With Eisenmengerization, volume overload goes away. PAH versus PS, whether there is pulmonary artery hypertension or pulmonary stenosis. This is very important. This drastically changes the management. Next is mixing. As I have said, mixing is very important in single ventricle. It is also very important in TGA. We want to promote mixing in cases of TGA because there is parallel circulation. Until and unless child goes corrective surgery or arterial switch operation, we want to promote mixing to prolong survival. In cases of then next topic is parallel and in series circulation. As we have discussed, normally series circulation, parallel circulation is there in TGA. Venturi effect. What is Venturi effect and why it is important? It is important in cases of VHD in any case of restrictive VHD. In restrictive VHD, there is possibility that AR can occur because of Venturi effect. Then pressure overload in cases of obstructive congenital heart diseases. Then Steele phenomenon, competitive flow, runoff phenomenon, energy loss. These are all very important physiological concepts for management of postoperative cases. So what are the factors that affect decision making? So underlying principles, clinical factors, type and severity of defect, associated defects, age at presentation, natural history, symptoms or saturation or functional class, PAH versus pulmonary PS or pulmonary artery hypertension versus pulmonary stenosis, pre-existing comorbidities and syndromes. As I have said earlier, I have omitted social and administrative factors like cost issues, availability of expertise at different centers, social support for postoperative care, etc. I will be mainly focusing on clinical factors. First factor is type and severity of defect. It determines urgency, mode of intervention and level of complexity of intervention. Example being in duct dependent lesions. If there is a duct dependent lesion, it is very urgent. So type of disease determines, or if there is duct is very small, it determines severity. This severe disease, severity of ductal constriction determines what kind of intervention and how urgent it is required. This is just one example. We will come to examples later, more examples later. Next is associated defects. I have included few examples of how associated defects are important and they change the management. In case of restrictive VHD, we normally follow them up, but restrictive VHD can develop AR because of Venturi effect, and then it requires intervention, mainly surgery. In cases of TGA VHD, surgery is required at generally 6 weeks of age. But in cases of if TGA VHD, which is commonly associated with coarctation, it requires surgery at earlier age. In cases of AVHD with TOF, surgical timing is different. In cases of PDA with coarctation, which is very common, modality or intervention will change. In cases of just coarctation, we can do balloon dilated, but if PDA is associated, we have to go for surgery. In cases of TOF with AP window, TOF is a lesion with decreased pulmonary blood flow, but if AP window is there and if it is large, it is a lesion with increased pulmonary blood flow. So management type changes. Then TOF with severe peripheral PS. In TOF, we can correct the TOF part, the RVOT obstruction we can remove, we can do pulmonary valvotomy, but if peripheral PS is severe, we have to take it into account before making any surgical decision. Then truncus with interrupted aortic arch. Truncus with interrupted aortic arch is again a duct-dependent systemic circulation and requires earlier surgery. Single ventricle with severe AVVR. Single ventricle is generally goes on Glenn and Fontan pathway, but if there is severe AVVR, atrioventricular valve regurgitation, it needs separate surgery and it changes the prognosis also. Age at presentation. So first of all, timing of duct closure. Duct closes within first 3 weeks of life. That is very important. If there is a case of duct dependent systemic or pulmonary circulation, we have taken that into account. before making any decision regarding management. Fall in PVR. So we do VSD surgeries by 3 to 6 months of age, because we know that by 2 months of age there is fall in PVR which occurs. So shunt lesions start to manifest after first 6 to 8 weeks of life. Then early versus late presentation. As we all know, we have to do certain surgeries in cases of, especially mainly in cases of shunt lesions or cyanotic congenital heart disease with increased pulmonary blood flow early rather than late, because in those cases pulmonary vascular obstructive disease or Eisenmengerization can develop. But then on the other side, if we do certain surgeries in earlier, like say in cases of neonates, higher complexity is there and they can ultimately lead to more number of complications. Then next is pulmonary valve implantation or conduit placement. Say for example, in cases of TOF, we have to put pulmonary valve, do pulmonary valve implantation also if patient is of more than 15 years of age. Or say for example, in cases of TOF with pulmonary atresia, we generally put conduit when child reaches 1 to 2 years of age, because any conduit placed before that will child is likely to require many more conduit replacements in future. Say then in case poor results of surgeries for single ventricle in adulthood. Single ventricles should ideally be repaired in childhood, Glenn at 6 to 8 months of life, then Fontan procedure 4 to 5 years of age. But unfortunately, multiple cases of single ventricle reach adulthood and they have not undergone any surgery. And then if they undergo Glenn or Fontan at that age, their results are poorer as compared to those that have undergone these surgeries in the childhood. Next is symptoms or saturation. So heart failure or unacceptable desaturation means that there is urgency of intervention is required. Or saying, for example, in case of exercise intolerance, in case of TOF with free PR, he needs pulmonary valve implantation. So especially if these symptoms are not manageable with drugs. So basically, symptoms or saturation demand intervention. PS versus PAH, pulmonary stenosis versus pulmonary artery hypertension, increased pulmonary blood flow versus decreased pulmonary blood flow. Or in other way, in case of increased pulmonary blood flow, whether it is hyperkinetic PAH or obstructive PAH, which is determined by clinical factors as well as cathoximetry. Between these two, plan of management changes drastically. In adults, mainly medical management versus surgical correction. Say for example, if a case with large conoventricular comes to you with labeled as Eisenmengerization syndrome and he turns out to have severe PS, he can easily undergo surgical correction of TOF. While in cases of just large conoventricular VSD with severe PAH, management changes drastically as well as the prognosis also changes. So this is the cornerstone of management, deciding about management, PS versus PAH. Then there are multiple pre-existing comorbidities which dictate management planning, like prematurity, chronic lung disease, bronchial compression in cases of shunt lesions like large VSD or large PD or large AP window, or in cases of TOF with absent pulmonary valve. Then there are multiple syndromic associations are there with congenital heart disease, like Patau or Edwards syndrome, or Down syndrome, or DiGeorge, Legele, Turner syndrome, William, Noonan, rubella. Multiple syndromes are there. So particularly Patau and Edwards syndrome, children do not survive beyond early infancy. So in those cases, surgical intervention is not generally warranted for congenital heart disease. Then in cases of Down syndrome, they are generally associated with severe PAH or disproportionate pulmonary hypertension. So that dictates early surgery as well as prolonged postoperative course and accordingly prognostication. Then in cases of, say for example, DiGeorge syndrome, it is commonly associated with hypocalcemia, or Legele syndrome is commonly associated with hepatic biliary atresia also. So these are the things which require other investigations also. Or neurological insult. If there is severe neurological insult, we have to first cater to that and then only we can manage congenital heart disease. Natural history. This is the most important part deciding management of congenital heart disease. In brief, Unoperated natural history of various congenital heart disease leads to various complications, including heart failure, pulmonary vascular obstructive disease, cyanosis-related complications, ventricular dysfunction, valve regurgitation, and infective endocarditis. All cyanotic congenital heart diseases require intervention, generally surgery, at some point of time. Case in point here being Epstein's anomaly and balanced single ventricle physiology. These are the clinical conundrums in which surgery can be delayed, but generally all cyanotic congenital heart diseases require intervention at some point of time. Next is AV canal defect and AP window. They also always require intervention unless they are Eisenmingerized. Next is ASD, VSD and PDA. ASD, only ostium secundum ASD can close. Less than 5 mm ASD is generally close by up to 8 years of age, and more than 8 mm size ASD is generally never close. So the thing is, we have to close those ASDs which are more than 8 mm because they are very unlikely to close. There is also 14% chance of developing Eisenmingerization syndrome in case of ASD, and 15 to 20% incidence of atrial arrhythmias in case of large ASDs in older age. In case of VSD, perimembranous and muscular VSDs can close on their own. 25-year survival is 87% in cases of small VSD, and small VSDs are generally safe to follow up. In cases of PDA, PDA can close up to 3 months of age, but PDA is also the lesion, first lesion to develop early Eisenmingerization syndrome amongst these three: ASD, VSD and PDA. So goals of treatment. What are the goals of treatment? For surgery, goals are shunt closure, like say ASD closure or VSD closure, PDA ligation, AVSD repair, or intraventricular tunnel repair, VSD closure in cases of DORV. Then establishing RV to PA path, that is unobstructed pulmonary blood flow in cases of like Seno shunt, TAP in cases of TOF or TOF pulmonary atresia with conduit. Then LVOT reconstruction, unobstructed systemic blood flow, that is arch repair. Unobstructed pulmonary venous return by atrial septectomy or TAPVC repair. Volume unloading of single ventricle like Glenn-Fontaine, and controlled pulmonary blood flow, that is in case of by BT shunt or PA band. So when to intervene? Importance and rationale of timing. Neither too early. Intervention should not be it should not be too early. Like neonates have friable tissues, they have smaller anatomies, nutrition and growth is their important factor, then they are more predisposed to infections, higher pulmonary vascular resistance is there. If certain surgeries are done early, then risk of recurrence or risk of multiple future surgery is there. Neurological insult due to bypass time can occur in smaller neonates and infants, while it should also not be too late. Like in cases of duct dependent and systemic and pulmonary circulations, then they can develop Eisenmingerization syndrome later if surgery is or intervention is done too late. There is risk of heart failure or developing aortic regurgitation or infective endocarditis or arrhythmia with time. So when to intervene? Optimized cath or surgical outcome without risk of delayed intervention. This is the goal. Optimized cath or surgical outcomes without the risk of delayed intervention. So we have to intervene when symptoms are not controllable with medicines. Say for example, there is a large VSD and we are managing with drugs, but child is still having failure to thrive. So we have to intervene with surgery. Then there is unacceptable desaturation. Say in cases of TOF, child is having saturation of 60-65. If we are able to manage with beta blockers and saturation is maintaining more than 80%, we can child can undergo surgery beyond 6 months of age at relatively ideal age. But if there is unacceptable desaturation, say for example in case of TOF, then we have to plan intervention earlier. Then natural history is supportive. So generally we do not want complications to develop. So we have to do surgeries at their ideal age. That is dictated by natural history. And there is lesser surgical risk than the disease course. Though there is a risk, but risk is lesser than the disease if disease runs its course itself. Then when not to intervene? say benign natural history is there. Tiny PDA is not going to, no complication can occur with tiny PDA. So benign natural history or very small VHD is there, we can safely follow them up. Then there is saturation or symptoms are manageable or acceptable, and then there is favorable natural history also. Then there is younger age with relatively asymptomatic status. Then risk of surgery is high or higher as the disease progress than the disease progression itself. Or lastly, severe neurodevelopmental issues or major chromosomal abnormalities are there. Emergency intervention is required. When the emergency intervention is required in cases of congenital heart disease. Top physiology with active spell, duct-dependent systemic or pulmonary circulation, obstructed TAPVC. In cases of TGA, intact septum with restrictive ASD, mitral atresia, tricuspid atresia or pulmonary atresia, intact septum or HLHS with restrictive ASD, or TOF with restrictive VSD, fulminant myocarditis or DCMP with severe LV dysfunction, congenital heart, complete heart block with bradycardia, certain post-operative conditions like block BT shunt, PA crisis, etc. But we are sticking to management of unoperated congenital heart disease here. Then, first of all, ASD. This is a very simplified management planning, and this is not an all-encompassing version. For ASDs, ideal surgical or intervention age is 2 to 4 years. Surgery versus device closure is decided by there should be at least 5 mm rim size, weight should not be less than 15 kg, and device size should not be more than 20 mm per meter square. Roughly it comes to about more than 200% of weight. Say for example, weight is 15 kg, device generally is not put more than 30 mm size. Then next is VSD. Small VSD, they are generally asymptomatic, no LALV volume overload, no cusp prolapse, no RVOT obstruction. They can safely be followed up yearly. Then moderate VSDs. If their LALV are dilated, there is signs of volume overload, intervention is required at 2 to 5 years of age. And if they are asymptomatic, but if they are symptomatic, intervention is required at 1 to 2 years of age. And then large VSD. Large VSD, in those cases, severe hyperkinetic pulmonary hypertension is there. So intervention is required at 3 to 6 months of age. Surgical intervention in the form of either corrective surgery or PA band is done. PA band is done in cases of multiple VSDs or inaccessible VSDs or child is having sepsis. Generally, corrective surgical intervention is done. Device closure is attempted where there is QPQS ratio is more than 1.5:1. Isolated perimembranous or muscular VSDs away from the aortic valve are there. Then in cases of PDA, small PDA, moderate PDA and large PDA all require intervention. Tiny PDA or silent or hemodynamically insignificant PDAs, they do not have any murmur and closure is generally not recommended. For small PDA with no LALV enlargement, no PAH, no signs of congestive cardiac failure, intervention is done at 12 to 18 months of age. Moderate PDA with mild LALV enlargement, mild to moderate PAH, and CCA that is controlled. Intervention in the form of PDA device closure is done at the age of 6 months to 1 year. This is the only PDA which has continuous murmur. Generally, very small PDAs and very large PDAs do not have continuous murmur. And large PDA with congestive cardiac failure or with severe PAH, generally intervention is indicated by 3 months of age. In cases of neonates with large PDA, surgery is the class 1 indication, device is class 2B indication. Ibuprofen or paracetamol, they do not have any role in term neonates. Then next is AV canal defect or AV septal defect, atrioventricular septal defect. There are two types, unbalanced AVSD and balanced AVSD. In balanced AVSD, there are again 4 subtypes: partial, transitional, intermediate and complete. In cases of partial or transitional AVSD with no PAH and controlled atrioventricular valve regurgitation, intervention is required at 2 to 3 years of age in the form of surgery. In cases of intermediate and complete types, surgery is required by 3 to 6 months of age. In cases of unbalanced ABCD with PAH physiology, PA band is done by 2 months of age. Or then if there is unbalanced ABCD with PS physiology, intervention generally in the form of Glenn is done at 6 months of age. Coarctation, transcatheter gradient of more than 20 mmHg, that is mean gradient on echo, they require intervention. And if there is gradient is less than 20 millimeters of mercury, but there is LV dysfunction or severe LVH or upper limb hypertension is there, or significant collateralization, that is more than 50% narrowing of DTA diameter is there, then intervention is required. With LV dysfunction or severe hypertension or congestive cardiac failure, immediate intervention in the form of balloon dilatation or surgical intervention is required. If there is no LV dysfunction, only mild hypertension is there and no heart failure is there, intervention is needed at 3 to 6 months of age. And if there is no LV dysfunction, hypertension or congestive cardiac failure, intervention is required at 1 to 2 years of age. In cases of neonates, surgery is class 1 indication. If neonate is critically ill and cannot undergo surgery, balloon dilatation or coarctation is done. In infants, again surgery is class 1 indication. In case of child less than 25 kg or infant with recoarctation, balloon dilatation is required. And in case of child with more than 25 kg weight plus more than 10 years of age, coarctation stenting can be done. Aortic stenosis, valvular aortic stenosis, immediate balloon aortic valvotomy if drug dependent systemic circulation or severe LV dysfunction is there, or if there is gradient more than 64 by 40 mmHg, peak by mean gradient, or at lower gradients if child is symptomatic or there are STT changes on ECG. In case of subvalvular AS, gradient is if more than 50 mmHg, peak gradient, or less if there is LV dysfunction associated with less than 50 mmHg gradient. In cases of supravalvular AS, gradient is if more than 64 by 50 mmHg or at lower gradient with symptoms or LV dysfunction or STT changes. We also have to rule out peripheral PS and coronary artery involvement in cases of supravalvular AS. Then pulmonary stenosis. Balloon pulmonary valvotomy is generally done in cases of valvular PA immediately if drug dependent pulmonary circulation is there or RV dysfunction is there, or electively if there is more than 64 mmHg of peak gradient is there. Generally surgery is done in cases of infundibular PS and supravalvular PS. Stenting or surgical both can be done in cases of branch PA stenosis. TOF. Children are generally given iron and beta blockers. Then surgery, that is ICR, intracardiac repair, is done at 6 months of age. We have to take 3 factors into account: age, saturation and PA size for TOF management. If age is less, saturation is good and PA size is good, we can safely follow them up till the ideal age. Then if age is okay, saturation is low and PA size is good, then they can undergo ICR. If age is again good, saturation is good and PA size is small, then they undergo PDA stenting or MITI shunt to increase PA size. Next is transposition of great arteries. TGA with intact ventricular septum, they generally undergo surgical correction in the form of arterial switch operation within first 3 weeks of age, and balloon atrial septostomy if they are particularly sick for surgery or with restrictive ASD. TGA with large VSD generally undergo surgery, arterial switch operation plus VSD closure within first 6 weeks of life. And then those who present late or late presenters, in cases of TGA with intact ventricular septum, and if they are presenting more than 2 months of age, they generally undergo arterial, in place of arterial switch operation, they undergo atrial switch operation, that is Senning operation. Or in cases of TGA with large VSD, who generally undergo surgery within first 6 weeks of life, if they are presenting after more than 6 months of life, then we have to check for operability in them. Then truncus arteriosus, they generally undergo surgery within first 2 to 3 months of life, that is truncus repair. They are one of the earliest to Eisenmengerize, so surgery is to be done quite early. And they also have the most common DD of them on echo is VSD pulmonary atresia or TOF pulmonary atresia, and management of TOF pulmonary atresia and truncus is quite different, especially age group is quite different, so we have to be very careful while diagnosing. Then next is TAPVC. There are 4 types of TAPVC: supracardiac, infracardiac, coronary sinus, and mixed TAPVC. But for all of them, if there is any form of obstruction, emergency TAPVC repair is required, and if there is no obstruction, surgery is generally done at 2 to 3 months of age. If saturation is less than 80% in case of TAPVC and age is beyond childhood, say more than 5 to 7 years of age, then cathoximetry is required to decide about operability. Because in TAPVC, saturation is generally in the range of 85%. If it is less, then there is a chance that they may have Eisenmengerized. Then single ventricle. So what are the aims of repair in single ventricle? There should not be no significant atrioventricular valve regurgitation, unobstructed systemic and pulmonary venous return, unobstructed systemic blood flow, and controlled pulmonary blood flow. We do not want excessive pulmonary blood flow or very less pulmonary blood flow. Then in cases of single ventricle, we want to promote mixing initially. Say for example, in case of mitral atresia, if there is AHD is restrictive, we have to enlarge the atrial septum. So we want to promote mixing initially, but we want to promote mixing later, at later stages. Say for example, after Glenn-Fontaine surgery, we do not want mixing of systemic and pulmonary circulations. Then we want to promote shunting initially in them, but we do not want to, and we want to prevent shunting at later ages. Like say for example, we do not want antegrade flow later, say when Fontaine has been done. This is a complex topic and requires different discussion and different and detailed discussion. Then overall, in single ventricle cases with pulmonary stenosis, PD stent or BT stent as per saturation and PSI is done. Then with pulmonary artery hypertension, PA band is done by 3 months of, within first 3 months of life, and if the age is more than 6 months, we have to check for operability. And BDGS or bidirectional Glenn shunt is done at 4 to 6 months of age, and Fontaine is done at 4 to 5 years of age. Epstein. In neonatal Epstein with duct-dependent pulmonary circulation, prostaglandins are required. If they are present with heart failure, diuretics are needed. I have simplified this approach into 2 types: Carpentier type A and B. They undergo TV repair by 2 years of age. Intervention is required in cases of Epstein when there are symptoms or cyanosis is and with cyanosis with saturation less than 90%, progressive cardiomegaly on chest X-ray, and progressive dilatation of RV or there is RV dysfunction. While in cases of Carpentier type C and D, they generally go on single ventricle pathway or 1.5 ventricle repair pathway. Then CCTGA, congenitally corrected transposed grade arteries. In cases of CCTGA with intact IVS, they generally undergo atrial switch plus arterial switch or double switch operation. That is generally done at around 6 months of age. VSD, CCTG associated with VSD, if they are less than 3 months of age, they undergo PA band. If they are between 3 to 6 months of age and or more, then they undergo double switch with VSD closure. In cases of CCTGA with VSD PS, if VSD is routable, they generally undergo atrial switch plus Rastelli operation, and if VSD is not routable, they go on single ventricle pathway. This is very simplified approach, but this generally works. Then next, in case of DORV, there are mainly 4 variants of DORV: VSD type, TOF type, TGA type, and remote VSDs. So their management is according to the associated disease. Like in DORV with VSD type, management is as per VSD. DORV with TOF type, management as per TOF, and so on and so forth. So I have made this simplified flow chart to aid in decision making regarding planning of congenital heart disease management. So in cases of any unoperated congenital heart disease, first of all, once we have done echo and other tests, we know that we have to ensure that there are 3 valves and 2 ventricles. So what is 3 valves and 2 ventricles? There should be a good size aortic valve, mitral valve, and tricuspid valve. pulmonary valve, even if there is atresia or hypoplastic, we can manage with 2 ventricle circulation and 2 good size ventricles. If aortic valve, mitral valve and tricuspid valve are good size plus LV and RV are of good size, child can undergo 2 ventricle repair. So first of all, if there are 3 valves and 2 ventricles, child can undergo biventricular repair, which is our aim. So in case of biventricular repair, once we know that child can undergo biventricular repair, then we need to know the basic underlying basic lesion. Say for example, AHD, VHD, PDA, TOF, AV canal, TAPVC, whatever. Then whether it is associated with pulmonary arterial hypertension, PAH or PS or balance physiology is there. Say for example, there is PAH. There is, say, basic lesion is VHD associated with PAH. Now we have to decide about whether a child is presenting at the age of intervention. If there is age of intervention is appropriate, child can undergo corrective surgery. Then or corrective intervention. If age of intervention is not appropriate, child can either be presenting early or late. If child is presenting early, then we look for saturation and symptoms. If there is saturation is low or child is quite symptomatic and not medically manageable, then we have to correct all causes for them, especially like in the form of we have to optimize medications, and we have to look for anemia, nutrition. We have to correct all associated causes. If child is still symptomatic after that, then early surgery or therapeutic cath or intervention is required. Now next is if saturation is not low and child is not quite symptomatic, then we have to look for associated lesions. If they need intervention, then again child will go surgery along with the repair of those associated lesions. If they also do not need attention, then child can be closely followed up. Then if there is age of intervention is not there, child is presenting late, so we have to decide about operability, and then only we can intervene. Next is PS. If there is pulmonary stenosis is there, then again we look for age of intervention. If child is presenting at age of intervention, we look for PS size. If PS size is adequate, child generally undergoes corrective intervention. If PS size is inadequate, he will undergo BT shunt or PDA stenting. Then if age of intervention is not there, then we again look for low saturation or symptoms. If they are there, child will undergo BT shunt or PDA stenting. And if saturations or symptoms are not there, child is doing well, we can closely follow them up. Sorry for this is not BAS, that is BT shunt, BTS. And next is balance physiology. In cases of certain single ventricles who present with balance physiology, we can safely follow them up, but we have to look for associated lesions. If associated lesions do not require intervention, we can safely follow them up. Then in cases of, if there are 3 valves and 2 ventricles are not there, then child will generally undergo either univentricular repair or 1.5 ventricle repair. So if, for example, tricuspid valve is relatively hypoplastic or smallish and RV is also relatively hypoplastic or smallish, child can undergo 1.5 ventricle repair. So that is I have written as 2.5 valves and 1.5 ventricles. That is, if tricuspid valve and RV are borderline, child will undergo 1.5 ventricle repair. So if such a situation is there, then we have to look for PA pressures. If PA pressures are normal, then he can undergo 1.5 ventricle repair, that is gland with integrant flow is open. And if PA pressures are high, then management becomes quite complex, and we have to decide about operability also. In cases of, now if there are 3 valves are not there, even 2.5 valves are not there, that is tricuspid valve is quite either it is very hypoplastic, or RV is very hypoplastic, or mitral hypoplasia is there, or aortic valve is hypoplastic, then child will undergo univentricular circulation or univentricular repair. So in cases of univentricular repair, again 2 things can be possible, either there is pulmonary stenosis or pulmonary hypertension. Say if case of tricuspid atresia, there is pulmonary stenosis is there, then we have to look for again age of intervention. If there is age of intervention is there, we assess for PSIs. If PSIs are adequate, child will undergo Glen or Fontan as per age. If PSIs is inadequate and PSIs is bilateral inadequate, child will undergo PDA stenting or BT stent. If it is unilaterally inadequate, child will undergo ipsilateral Glen on one side and BT stent on other side for PA growth on that side. Then say if univentricular circulation age of intervention is not there, then we have to look for saturation or symptoms. If there is saturation is low or child is quite symptomatic, he will again undergo BT stent or PDA stent. If child is overall doing fine and is early for the intervention, we will closely follow him up. If he is late, then again we have to go for PSIs, assess PSIs, and then intervention is decided. Then in cases of univentricular surgical repair, there is PAH. PS is not there. Pulmonary artery hypertension is there. Then we go for again go for age of intervention. If age of intervention is there, child will generally undergo PA band with associated lesions repair. And if age of intervention is not there and child is early, then we will assess for saturation or symptoms. If saturation and symptoms are there, child is symptomatic or saturation is low, we look for other causes and then treat them and eventually PA band. If child is doing well with maintaining saturation and symptomatic is not symptomatic, then we will look for associated lesions. If associated lesions require intervention, he will undergo PA band with associated lesions repair. And if associated lesions do not require intervention, we can safely follow him up. Then if there is a child is presenting late, there is PAH is there and child is presenting late and he is presenting beyond age of intervention, then we have to decide about operability and then only we can intervene. Next is, then there are, lastly there are, uncertainties in decision making. There are certain gray zones. So lastly we will be discussing about uncertainties in decision making. As we have already seen, there are multiple factors which affect decision making in congenital heart disease. But despite knowing and considering all those factors, there are certain gray zones where individual decision making is required and there is evidence is very flimsy or not there. Say in cases of small PMVHD, very small PMVHDs are generally followed up, but then there are multiple institutes which perform device closures or surgical intervention in cases of small PMVHD. We have to have robust evidence regarding their follow-up and their natural history. Then tiny subpulmonic VHD with trivial AR. If there is tiny subpulmonic VHD is there with any degree of AR, we generally go for surgery. But if it is very small, AR is also not very significant, then decision making is difficult in cases of subpulmonic VHDs, because subpulmonic VHDs do not close on their own. Then isolated PAPVC, just LUPV to innominate vein or RUPV to SVC are a junction. In those cases, whether surgery is required or not, that is difficult to decide. In cases of small coronary cameral fistulas or in cases of non-obstructive subaortic membranes with no significant AR or no significant AS, then in cases of single ventricle with balanced QPQS physiology, in these cases gray zones exist. We are not having any robust evidence regarding management, so decision making in these cases is relatively difficult, but these are the gray zones areas that we have to identify. Thank you.